Good evening, everyone, and welcome to tonight's Adult Congenital Heart Association webinar, What's New in Anticoagulation. I'm very pleased and excited to have everyone here, and thank you for joining us. I would also like to take this opportunity to thank Actelion Pharmaceuticals, Gilead Sciences, and St. Jude Medical Foundation for their support of this webinar through an unrestricted educational grant. For those of you who don't know me, I am Paula Miller. I'm the Senior Education Manager here at the Adult Congenital Heart Association. And along with Danielle Howe, who is our Director of Programs, we will be moderating tonight's webinar. If you have any questions during the course of the presentation, please feel free to send them to me by clicking on the Questions and Answers tab that is on your control panel and type in your question. You can certainly send your questions at any time, but we will hold all questions until the end of the presentation. We will also only take questions that are general and specific to the topic of anticoagulation, and we will only be able to answer one question from each of you until we are able to get through all the questions. We will not be able to answer any questions that are related to your specific medical situation, but we'll encourage you to discuss those with your own adult congenital heart disease cardiologist. And we will try our best to answer all questions, but if we are not able to, again, please ask those questions of your ACHD cardiologist. It's my pleasure to have Dr. Karen Stout with us tonight to do this presentation. Dr. Stout directs the ACHD clinic at the University of Washington and Seattle Children's Hospital. She is trained in adult cardiology and then acquired additional training in congenital heart disease. She sees patients both at the University of Washington and Seattle Children's. She also has expertise in echocardiography and pregnancy and heart disease. Dr. Stout is a member of the ACHA Medical Advisory Board, and in her spare time, she enjoys snowboarding, travel, and other outdoor hobbies. So it is now my distinct pleasure to introduce Dr. Stout.
Hi, everyone, and thanks, Paula. I've got the slide up here thanking our sponsors who helped make this possible. So thanks to Actelion, Gilead, and St. Jude. And although the title of this talk was originally Anticoagulation, What's New, I think probably everybody is really more interested in the newer anticoagulants that you may have heard about, maybe considering, that sort of thing. And so I'm going to really focus on those, and I'm going to focus towards the end in particular of whether or not they are something that ACHD patients can use. And looking at some of the attendees, there's a physician or two on there, and I'm going to start out with some stuff that's going to be a review for some of you and maybe new information for others. And we'll get going. I don't have any disclosures. So I don't have any investment in any form with any drug company or device company. So what I'm going to do is I'm going to run through the clotting process, because one of the things that I find in clinic is that distinguishing between anticoagulants is not always so obvious exactly what we mean when we say that word. I'm going to go through some of the types of medications, the newer ones, what's different about them, and what do we know about how well they work, and then which ACHD patients may actually be able to use them. So the first thing I'm going to talk about here is clotting, and this is the clotting cascade or coagulation cascade. And over here on the right, or your right, maybe your left, whatever, the red thing is the coagulation cascade as in clot formation, and then fibrinolysis is the breaking down of clots. So what I want to kind of draw your attention to is there's two parts of the clotting cascade in general. One are cells, which are platelets. So there's cells out there in the bloodstream that participate in forming clot. There's also a bunch of proteins, and that's this factor 12 and factor 12A and 11A and all these things, and tissue factor and all these abbreviations. Those are all proteins, and we're going to impact those two different things in two different ways. If we want to make the platelets more slippery, and over here are the clot busting sorts of things, and we're not going to touch on those very much, because really what we're focused on are the drugs over here that inhibit clotting, not so much the ones that will break up a clot that's already there. So if you look at things that are going to impact cells, it's specifically the platelets we want to impact, because they're the guys that form clot, and we want to kind of make them slippery. And the classic drug to do that is aspirin or clopidogrel. Some people may have heard of ticagrelor. There's a couple of different aspirin-like drugs out there. Clopidogrel is also called Plavix. So those two drugs are antiplatelet agents, and they affect the platelets, but they don't affect these proteins. And the proteins are really kind of the focus of the newer drugs. When we talk about anticoagulation, we are in general in the medical community talking about things that inhibit proteins that are affecting clot formation, not the cells. So these we'll call antiplatelet therapy, and stuff up here that impacts the proteins, we will call anticoagulation. So warfarin or Coumadin, heparin, enoxaparin or Lovenox, and what you may have heard abbreviated as the NOACs, or novel oral anticoagulants. And those are the ones we're going to talk about. If you've ever happened to have had a clot that required blood, some sort of clot busting drug, those are the ones that are over here, and there's not really much new in that world. The biggest thing that's new in anticoagulation are these NOACs. So the types of medications, aspirin and clopidogrel or Plavix, affect platelets. So they're the ones that if somebody's had a heart attack or is at risk for heart attacks, they will be on aspirin. If they've had a heart attack or had a stent placed to treat a heart attack, then they'll probably be on aspirin and clopidogrel or Plavix. Some people are on aspirin for stroke prevention, and it's typically the folks who have hardened arteries or atherosclerotic disease, coronary artery disease, peripheral vascular disease, kind of that disease of aging and high cholesterol and high blood pressure and smoking. Those folks will be on stroke prevention medication with aspirin and maybe that clopidogrel or Plavix as well. For our congenital heart disease patients, if you've had a stent put in, so if you had coarctation of the aorta and a stent was placed, or if you had an ASD or a VSD closed with a device rather than surgery, you'll often be on aspirin for, say, 6 months after those things are placed. And that's pretty common. And then there are a subset of adult patients where somebody may use aspirin to try to prevent stroke due to arrhythmias or atrial fibrillation in particular. And that is something that's not done as commonly anymore and is a little different than the strokes that are caused by hardened arteries. But sometimes you'll see people on aspirin for prevention of stroke due to arrhythmias. In our congenital heart disease patients, for those patients who have single ventricle physiology treated with a Fontan repair, it's not real clear what the right answer is in terms of blood thinners, and so sometimes people will be on aspirin as just a general clot prevention for certain types of heart disease. So while I've listed things there, those aren't the only reasons that somebody might be on aspirin, and you may find that your cardiologist put you on aspirin for other reasons. For people who've recently had valve replacements, for example, sometimes they'll be on aspirin for a period of time after the valve was replaced and maybe not lifelong. The ones that we're kind of here to talk about more are the protein affecting medications. So warfarin, which affects these vitamin K affiliated proteins or affected proteins. Heparin, which is an IV or subcutaneous drug. So it's an injection in some form. Enoxaparin or Lovenox, which is also an injection. And then the novel oral anticoagulants. As I'll point out a little while later, the novel piece is they're maybe not so novel anymore. They've been around for a while, so the name is starting to change. These are usually used for treatment of or prevention of stroke. If somebody's had a stroke related to a clot in their heart that flipped off to their brain, which is most commonly going to be related to atrial fibrillation or atrial flutter, so abnormal heart rhythms coming from the top part of the heart. For people who have mechanical valves, they'll be on warfarin or Coumadin. And if anybody's had a clot out in one of their veins or had a clot that's gone up to their lungs, they may be on Coumadin as well. In the hospital, heparin or Lovenox are pretty commonly used, enoxaparin, instead of warfarin, just because warfarin's fairly long lasting. For any of you, and I recognize a few of the names on the list as folks who may have had encounters with warfarin, if you've had encounters with warfarin or Coumadin, one of the big downsides to that drug, there's two in particular. One is that it requires that you check blood levels to make sure that you're actually in the therapeutic range that's appropriate. So not too thin, not too thick. The other downside to the drug is that Because it works through vitamin K, there's a lot of dietary things that end up being a big deal about making sure that your levels stay pretty stable. So vitamin K containing foods like leafy, dark green leafy vegetables, liver, a variety of things along those lines, if they have a lot of vitamin K, so right now it's summertime, you may be into the spinach salads. If you're taking Coumadin, you got to be pretty consistent about how much spinach you eat and how much vitamin K containing food you eat, because your levels can swing around a lot depending on what your diet's doing or what you're doing with your diet. They also interact with medications. Coumadin's kind of notorious for interacting with other medications, and if you end up getting put on antibiotics and it changes the bacteria composition of your gut, that can change your vitamin K levels, which can make your INRs higher or lower. So warfarin's kind of a tricky drug to take. People get into a groove and they do great with it after a while, but there's just a lot of stuff you have to kind of be mindful of, especially when you first start with it. Heparin doesn't so much, but it's only given either IV or subcutaneous, and Lovenox, same thing. And then these novel oral anticoagulants we'll talk about coming up here. Adverse effects of all of these are important to bear in mind, and they tend to all be about the same for each category of drugs. So aspirin and clopidogrel, these guys are preventing clots, so therefore they could cause bleeding. And it may be external bleeding, so like men who are on those, or shaving their face, or women shaving their legs, or if you don't shave at all, if you just go whack yourself against a door, you may just find that you bleed a whole lot more and bruise a whole lot more, bruise more easily, for example. Some people can have GI bleeds or gut bleeds from their stomach or somewhere in their colon. And then around procedures, you may have some more bleeding, like if you had to have a cardiac catheterization or some surgical procedure, they'll often, for surgical procedures, ask you to stop your aspirin or your clopidogrel in order to minimize bleeding related to the procedures. Aspirin and clopidogrel can cause stomach irritation as well. So they're typically recommended to take them on after a meal or with a meal. Warfarin, heparin, and enoxaparin, and any anticoagulant in that class can also cause bleeding. It can be external, same thing. You can bruise really easily. You get a nick, you may bleed more than you're expecting. You can have GI bleeds, and you can have bleeding around procedures, so cardiac catheterizations or that sort of thing. There's also, at least in the studies, a concern for intracranial hemorrhage or bleeding in the brain. That could happen with aspirin or clopidogrel as well, but tends to be a bigger focus of the studies, at least on warfarin and the novel oral anticoagulants. So what are the NOACs? What's so novel about them? So if you look over here on these different factors that are proteins that contribute to clot formation, historically, warfarin and heparin, they all act indirectly on how these proteins work. These newer agents, rivaroxaban, apixaban, and dabigatran are the ones I'm going to focus on. Edoxaban is a new one that's coming out as well. They all have similar names. The names you may know them by are Eliquis, Pradaxa, and I always forget the other one, but I'll remember it. The brand names are easier to pronounce than the generic names for sure. So these guys affect different things very directly. They affect the proteins directly. They don't have anything to do with vitamin K, for example. And so they have a significant effect, but the hope is that by not interacting with vitamin K and not having much interacting with other medications, that they would be more effective in both preventing clot formation, but also maybe less likely to cause bleeding. So the novel oral anticoagulants, dabigatran, rivaroxaban, apixaban, they're now getting called direct oral anticoagulants, or DOACs. So if your physicians are using, or somebody's using those terms, they mean the same thing. They're just getting at the idea that at some point something's not so new and novel anymore and has been around. And this gets more at the idea that these directly impact the proteins that they're interacting with. So the three that are out there most commonly right now are dabigatran, rivaroxaban, and apixaban. If you happen to play Words with Friends, it's a crying shame that these are not actual words on Words with Friends, because they'd be worth a whole lot of points, particularly rivaroxaban, if you could somehow or another come up with that many letters. So let's consider these drugs right now and think about maybe a case where somebody might ask about using it. Look at what data is out there, and I'll tell you right now that it's not on adult congenital heart disease patients, but I want to give you an idea of where it might come up for you or your family members, and then I'll give you my own thoughts and opinions. So I'm going to start with a 20-year-old double inlet left ventricle patient who was treated with a lateral tunnel Fontan. If that sounds like a bunch of mumbo jumbo to you, that's fine. The important thing to know is it's fairly complex congenital heart disease that is prone to clot formation. Has a history of a CVA or stroke in childhood, but is completely fine now, and had one episode of a tachycardia when she had pneumonia back in age 13. Is now 7 years later, has never had another episode. And the reason that's important is this particular type of heart disease, plus an atrial arrhythmia, and then a history of stroke, all kind of suggests that we ought to do what we can to prevent clot formation that could go off and cause a stroke. She's a college student. She's playing soccer, she snowboards, but that measure of the effect of the warfarin, the INR, has been fairly variable, and she owns it completely. You know, college is a tough time to be really consistent with your diet and to get your labs checked regularly. So she was watching TV, saw an advertisement for, I think it was Pradaxa at the time, and thought that, and it's actually a she, not he, came in and was like, hey, I saw that on TV. Is that a drug that I could take? Because they make it sound like it's better. And then she actually asked some family members, and her grandfather was on Eliquis. And so they got into a conversation and it said, hey, would this be a better drug for me? So I think that's a really legitimate question to ask. So the thrombosis issues that come up, the clot forming issues for adult congenital heart disease patients. One is that you may have an increased risk of either stroke or just clot formation, depending on the individual patient's underlying anatomy, physiology, surgical repairs. Do you have shunts? Do you have a mechanical valve? Do you have a tissue valve? All those things, if you've got some of those, it could increase your risk of some sort of clot formation that isn't good. There's also a bunch of younger folks, or just folks in general, who may not do great with warfarin, and that's not at all specific to adult congenital heart disease patients. Patients on the whole can struggle to really get their INRs right in the range that they need to be. And if you travel for work, or you know, you're relying on your garden for your food or that sort of things, it can really kind of be hard to deal with the dietary stuff. The one thing that's super important to know is that congenital heart disease patients are not included in all of these trials of stroke prevention, and therefore are not represented in any of the things that we really know about these drugs. So we're always going to be extrapolating at this point from other patient populations to those who have congenital heart disease and just trying to make it as specific to the individual patient as we can. And for those patients, for example, with a Fontan repair, even in that setting where there may be a real particular appeal for these medications, we still haven't entirely decided who does or doesn't need routine blood thinners. So somebody who has a mechanical aortic valve, for example, or a mechanical mitral valve, we have a really good sense of what's necessary in terms of anticoagulants in those patients. But for patients like the patient I described, we are not entirely clear yet as a community as to whether or not people need to be on blood thinners. Does everybody with a Fontan repair need to be on one? Is it only certain patients? And if so, which patients? Are some people okay with aspirin? And so far, it's not entirely clear. So that makes it a little hard to then say, well, we know you should be on Coumadin and this other drug might be a reasonable alternative. If we haven't even really sorted out if somebody really needs Coumadin, it gets a little harder to then make that next leap. So I just say that so that as we go forward, you kind of recognize that the most important thing is to individualize your care with your adult congenital heart disease cardiologist or your electrophysiologist, as the case may be. So here's a little bit of data of the things we consider. So the reason that this patient was asking about whether or not she could be on a different blood thinner, this is a hint. This is just to give you an idea of some of the data that's out there. This may not apply to most of you on the phone. So here's a study of 30 patients, mean age is 26 years, and 30% of them have a history of some sort of atrial arrhythmia. They are the patients who have a Fontan repair, and this is a type of echo, a transesophageal echo, where we put the ultrasound probe down the throat. Some of y'all may have had them. And what this is showing is if you kind of just look at that smoke, as we call it on echo, it just looks like real sluggish blood flow. When you have that kind of sluggish blood flow, you want to have people on blood thinners so that they are less likely to have that turn into clot formation. And that's just an example of one of my patients. But this study suggested that in this group of patients, 17% of them had a pulmonary embolus, so had clot that went out to the lungs. And this is an example of what that might look like on an echo. So this is an echo on a guy who just came in for routine screening, hadn't been seen for a good number of years, like 10. And although he was on Coumadin, he had developed a clot here. This is his pulmonary artery. Had developed a clot sitting out there in his lungs. So in this particular study, it just emphasized that Fontan patients are prone to clot formation, and sometimes they're prone to clot formation even if they're on drugs that should prevent it. So that's not to alarm all y'all who have Fontan repairs if you happen to be on the phone. That's just to emphasize that it's a real concern, even though we haven't really quite sorted out exactly what to do about it. So if we use that example that goes back to the case that I showed you, then what about some of these newer drugs? So here, dabigatran is the drug that's been around the longest, and it was the first one studied. So I'm going to emphasize some of it. It is a direct oral thrombin antagonist, so it's not an antiplatelet agent. Its half-life, so how long it works, is about 12 to 14 hours. So it has twice-a-day dosing. And we're going to get to the whole twice a day versus once a day. For those of y'all who haven't encountered Coumadin, it is a once-a-day drug. Half-life's 12 to 14 hours, so it starts fading. So you really do need to take it twice a day or you're not getting its maximal impact. There is this thing called cytochrome P450, which is a system in the liver that metabolizes medications. And it doesn't metabolize all medications. Only certain medications are metabolized by this. But Coumadin is one of the ones that is. There's a lot of drugs that interact with this, and it's one of the reasons that Coumadin has so much interaction with the other medications that are impacted by this particular system. So dabigatran has nothing to do with this stuff, so it doesn't have the same number of interactions with other medications. The one thing about it, though, is you actually can't really measure its effect. It doesn't have an INR. You're not treating to anything. It's like aspirin, where you just take it and you expect that it works. So for people who are used to aspirin, this is not that big a deal. For people who are used to Coumadin and they're used to knowing whether or not they're in range, to not know whether or not they're really like getting the effect that they think they're getting is a little hard to kind of get their heads around and to kind of be comfortable with. There's a lab called a PTT, which is usually what we use to measure the effect of heparin. There's also something called a thrombin time, and then the INR that's used to measure the effect of Coumadin. All of those could increase with dabigatran, but they don't accurately reflect the therapeutic effect. So you can't use those to track how well the drug is working. You just have to take it at its dose and assume it's working. That actually is a fair assumption, but when you've got adult congenital heart disease patients that haven't been thoroughly studied, we just have to all keep that in the back of our minds that we're making the leap from what has been studied to folks where it hasn't been studied. And there is one way, though, to kind of check and make sure that maybe it's not supra-therapeutic, which is that if this one lab value is over 2 times normal, it might suggest that the levels are higher than need be. So another thing to kind of be aware of is, and I want to orient you to this as we come into the studies that I'm going to show you, is there's a score. Atrial fibrillation is an irregular heart rhythm from the top part of the heart. Atrial flutter is a similar rhythm. Each of those rhythms have an increased risk of stroke, and that increased risk of stroke increases further in certain circumstances. So we have 2 different risk scores that we use. One of them is this thing called a CHADS score, and the other is the more updated version called a CHADS-2 VASC score. So they're abbreviations. So in the original score, which I show you because the studies I'm going to show you use this score, if you had a prior stroke or a transient ischemic attack, one of those baby strokes that doesn't last, then you get 2 points. If your age is over 75, you get 1. If you have hypertension or high blood pressure, you get 1. If you have diabetes, you get 1. And if you have a history of heart failure, you get 1. So based on those points, then you can figure out what somebody's stroke risk is over the span of a year. The newer score that we use mostly, which is this guy here, gives you 2 points for a prior stroke, 2 points for age over 75, 1 point for age 65 to 74, 1 point if you're a woman, 1 point if you have hypertension, 1 for diabetes, and 1 for heart failure. So really important to know that this is only for patients with atrial fibrillation. So if you've never had atrial fibrillation before, then this does not apply to you. But if you've ever had atrial fibrillation, there's a general tendency to try to use these scores to help decide whether or not you'd benefit from a blood thinner, specifically from anticoagulation. The thing to know is that adult congenital heart disease patients were not used in any of these studies. So there is some data that these scores might apply, but there's other data that says that maybe the CHADS2 VASC score actually does not accurately assess the risk of patients, particularly with complex congenital heart disease. But if you look at that, if somebody has a score of 6, their annual stroke rate is actually quite high related to atrial fibrillation. So in those patients, then blood thinners are probably going to be a really good idea. Notice, though, that in this particular study, there weren't very many patients who had a risk that high. But there were a lot who had kind of this mid-range risk here, CHADS2 score of 2 or 3, which gives people an annualized stroke risk of 4 or 6. So that can be cut down quite a bit by giving blood thinners. And if you look at cardiology, adult cardiology, all of our studies have these goofy acronyms. So this one's called RELY for some reason. And this was looking at Coumadin versus dabigatran. And this was the original study looking at warfarin versus 2 different doses of the dabigatran. And notice it has 18,000 patients. Remember that study I showed you on Fontan patients that had 30. So that's one big difference between adult congenital heart disease patients and patients with acquired cardiovascular disease, is there's way more folks with acquired cardiovascular disease. So it's way easier to study in this type of format if you have that kind of numbers. So the event rates, 1.7% on warfarin over the study period, and a little bit lower on the 2 different doses of dabigatran. The bleeding risk was a bit higher, 3.3% on warfarin, than it was on the lower dose of the dabigatran. The mean age of these patients, though, was 71, and their CHADS2 VASC score was 2, and the follow-up was over 2 years. So if you look at these curves over the span of 2 years to here, and then they extended it a bit, if you look at their risks, it looked like the dose of, the higher dose of dabigatran was at least as good as warfarin in terms of bleeding events, but they had fewer strokes, fewer clots, which gave the first hint that perhaps this was going to be an effective drug that actually worked at least as well as warfarin, but didn't come with a lot of the stuff to do with it in terms of drug interactions or levels that need to be followed or that sort of thing. So there's another study looking, and this one might apply a little bit more to some of our patients who have, like our Fontan patients, where we're worried more about vein clots than we are clots over on the other side of the circulation. So dabigatran and warfarin in this particular study were pretty similar. When we say something is a non-inferiority trial, if you have a standard therapy and you know that it works, anything that new that comes along, the first thing that we're going to do is try to make sure that it's at least not any worse than the thing that's already out there. And if it's not any worse, then you can start haggling about doing trials to prove whether or not it's actually better. But this was an early study, you see it's 8 years old, that was done for people who had clots in the veins or had had a pulmonary embolus, so clots that went up to the lungs. In this case, it's a younger population, 55 years, and coming up on half of them were women. One thing that's really important about the difference between warfarin and these newer anticoagulants, and I'm going to come back to this as far as whether or not one of these drugs might be right for you, is that in this study, and people who participate in studies are very closely monitored, like they're really dialed in. And even in this study, this INR of 2 to 3, which is what they wanted their goals to be, patients achieved it only 60% of the time. And sometimes that's because the patients are just not very consistent in taking it, or they've got dietary changes, or they're being given medications that are messing with things, or they just happen to be one of those patients where they just can't get the levels in range. And so when they looked at those, if you looked at this study and estimated the risk, in this case, the higher numbers are worse, and these lower levels are better. So if you look at dabigatran and any bleeding, warfarin and any bleeding, the dabigatran actually didn't have as much bleeding. And up here, the overall events were about the same. And one of the suppositions, one of the ideas behind why these drugs, dabigatran and the others, may be in some ways better than Coumadin is that they're not messing with this, are people in range? So if they're below 2, then they're not getting the benefit in terms of clot prevention. And if they're over 3, then they're going to have an increased risk of bleeding. So if you don't have those swings, and you shouldn't have that with dabigatran if you take it the way it's prescribed, then theoretically you should have fewer bleeds because people aren't getting supra-therapeutic. They're not having too much of an impact. And you maybe even have fewer clots because they're not as likely to be under levels. And that's kind of what these studies suggested, is bleeding was at least better and the clot formation was probably about the same. So the summary that everybody took from dabigatran is that it's probably better than Coumadin for preventing clots in veins or preventing pulmonary embolus. And based on this data, it was also approved by the FDA for treatment of non-valvular atrial fibrillation. So the key here is that people who had atrial fibrillation and had a stroke risk, it is an okay and accepted drug for those patients. The non-valvular piece is important. The only patients that were studied in those trials had to not have any significant mitral valve disease or aortic valve disease, because those patients may have a higher risk for stroke to start with. So they were excluded. And if you are aiming to be on one of these drugs, that's something that you got to bear in mind, is that there's still a thing out there for the non-valvular atrial fibrillation as being an indication, and some insurance companies will push back on giving people these novel oral anticoagulants if they happen to have valve disease. So the effect, though, if somebody has liver or kidney problems and they don't have normal liver function, or their kidney function is either not normal at baseline or fluctuates, the effect can be prolonged. And so the drug may not be great for people who have liver or kidney dysfunction. And if somebody has significant kidney dysfunction, and definitely if they're on dialysis, it's not a good drug at all and can't be used. The other thing that's important to know is, true of all of these drugs, so if you're on Coumadin, there are two ways to reverse the effect if you need to. So if somebody came in, for example, and they had a bleeding stomach ulcer, and we wanted to reverse the effect of the Coumadin, we can either give vitamin K, which will reverse it over the span of maybe 24 to 48 hours, or we can give somebody what's called fresh frozen plasma, which gives back a bunch of the same proteins and vitamin K related proteins and kind of reverses the effect more quickly. The thing about dabigatran is it is not as easily reversed, and the agents that are used to reverse it are not as widely available. So if you have a significant bleed, this drug may be more problematic. And when it first came out, that was actually one of the biggest concerns with it, is that as people started using it and they were running into bleeding issues, they were having troubles reversing it. Now that has gotten better because the people that make dabigatran have made a reversing agent for it, but it needs to be more broadly available. So for the adult congenital heart disease patient, for dabigatran, which is the longest one, it may be longest around one, it may be a possible alternative to warfarin in patients who have non-valvular atrial fibrillation. So if you happen to have basically kind of potentially could have fit into one of those trials, then certainly this could be an option for you. And anybody who's got kidney or liver function that changes, it may not be a great drug, and the lack of the easily available antidote could be problematic. So even though dabigatran is the one that's been around the longest, it's the one that's called Pradaxa, it's not the one that's getting used most often these days. Apixaban is getting used quite a bit, and this got a clever study name called Aristotle. It is another oral direct anticoagulant. It affects a slightly different area than the dabigatran. Here's another giant study. This is 18,000 people. Again, this is the same group that we studied before with the dabigatran, non-valvular atrial fibrillation or atrial flutter. Same mean CHADS-2 VAS score of 2, which was a stroke risk of about 4% per year. Mean age 70, so older patient population, about a third women. And this was another of these non-inferiority trials. And it suggested that in this study that it was not only not inferior, but it actually may have had fewer clots, fewer events in general, and fewer bleeds, and overall a lower mortality. The important thing is that it actually wasn't designed to study mortality. So when we see studies, we have to pay attention to what they were designed to answer. The only thing it was designed to answer is this stuff any worse than warfarin? And the answer was no. But they got some hints that maybe it actually is better than warfarin. And some of that goes back to the idea that you don't have fluctuating levels when you take this stuff. Rivaroxaban, another one, and it's one that is used, this is really commonly used, and it's really commonly used because it's once a day dosing. So another giant study, 14,000 patients, same thing though. Mean age 73, same group of people. This is a higher risk group. Their mean CHADS-2 VAS score was 3.5, so their stroke risk is north of 6% per year. And in this case, it's a fixed dose of one of 2 doses, and it's once a day dosing, which is really appealing for people who didn't want to do the twice a day that the other 2 drugs are. Another non-inferiority trial. It is not any worse than warfarin. In this case, overall bleeding rates were really similar, but in the people who are taking the rivaroxaban, they had fewer intracranial bleeds, so fewer brain bleeds, and fatal bleeding was less frequent, although that was so infrequent in general that it's a little hard to say that it's clearly better than that. This intracranial bleeding thing, part of what we're trying to prevent here are bad brain events. A stroke is a clot that goes up and blocks or one cause of stroke. The cause we're trying to prevent is clot that goes flipping up into the arteries in the brain, but you also don't want to have any bleeding in the brain. So if you have a drug that can actually have fewer bleeds in the brain, that's clearly going to be something we're going to be interested in. So how do we reverse the effect of any of these drugs? There's something called prothrombic concentrate that was used both to see if we could reverse rivaroxaban and dabigatran. And in this stuff, the rivaroxaban effect was reversed, but the dabigatran wasn't. So the makers, I actually randomly ended up in a cab once in a meeting with one of the executives from the company that makes dabigatran, and at the time they were working on an antidote for their medication. And since this study was published, they have come out with that. So there is something that can be used to reverse this effect, but rivaroxaban and apixaban both have this stuff that can be used and is pretty widely available to reverse the effect if need be. So that's at least getting somewhat safer. So if we compare these drugs, now let's remember that warfarin is taken once a day. You have to be mindful of your diet. You have to be thoughtful about consistently taking in vitamin K in the same levels pretty much daily or at least weekly. You have to be thoughtful about alcohol consumption, because if you drink too much, it can affect your INRs. And medications may mess with it and give you either too high a level or too low a level. And it is, on the other hand, pretty easy to reverse if the levels are too high and there's bleeding. And it's really widely available, and the medication itself is not that expensive. But Coumadin does require that you have INRs checked and levels checked. And in general, that means you have to come into an anticoagulation clinic, although some people can use home monitors in addition to coming into the anticoagulation clinic. So if you look at these 3 drugs, dabigatran, rivaroxaban, and apixaban. So using the dosing thing, BID means twice a day. So the dabigatran and the apixaban are twice a day drugs. Rivaroxaban is once a day. So this is at least the same dosing interval as Coumadin. These guys, you got to do it twice a day. And that can be we know that across all patients, once you make a drug twice a day, people are much more likely to forget a dose. And that's true of physicians. It doesn't matter who you are. That's just human nature. An easy antidote, when I did this slide, it was no, but now it's out there. So it's available. It's just not as widely available. Rivaroxaban and apixaban have an antidote, if you will. GFR means glomerular filtration rate. It's essentially a measure of kidney function. And if you have significant kidney dysfunction, dabigatran is not an option, rivaroxaban is not an option, apixaban could be. You can do a lower dose and still have some effect. FDA approval, it is approved for non-valvular atrial fibrillation and atrial flutter and deep venous thrombosis treatment or prevention. So that's what the FDA is approved. Doesn't mean that that's the only thing that gets paid for by insurers, but it does mean that if you have something that isn't something that's already approved, the insurance company can very easily push back. The medications themselves are expensive, but they were priced, as I was told, to be similar to the cost of the Coumadin pill, which is really inexpensive, and the INR draws, which are not. So the idea is that over the span of a year, the cost should be similar. But because the insurance companies look at the drug pricing different from the labs that go with it, they will often say, no thanks, I'm not interested in paying for these expensive medications when Coumadin is a perfectly reasonable drug, even though the whole net cost may be very similar. So what about ACHD patients? So the straight up answer is we don't know if these are the right drugs for patients with adult congenital heart disease. either as a whole group or with specific types of congenital heart disease. There are no randomized trials at all. There is a really broadly growing anecdotal experience. We have a couple of patients on these. We follow a lot of patients. We follow 3,000, 4,000 patients. We don't have very many on these medications, but we have a few. And the reason we don't have very many on them is that for the most part, if you have a reason to be on Coumadin, unless it's really a struggle to be on Coumadin, then these may not be very appealing drugs. The patients we've got have taking these medications, a couple of them travel a lot, and it's really hard for them to get their INRs checked and keep their INRs in range. Others, Coumadin was not a drug they could take. They weren't interested in, they tried it. For whatever reason, they just couldn't and wouldn't do it. And in other cases, for whatever reason, they just couldn't ever get a formulation of Coumadin or warfarin that worked well for them. So there's an anecdotal experience that's growing, which is going to be really helpful. And importantly, related to that, there's a registry one registry is being run by a group in the Netherlands of having all of us just contribute information about patients who are on the medication, not patient-specific information, like there's what type of heart disease and that sort of thing, but none of the identifiable features. So those registries, I think, are going to be super helpful. There are some case series. If you go look up in the medical literature, there's a number of case series of like, hey, here's what happened to the 30 patients that we gave these drugs to. But they're not randomized. It's just the physicians decided they could use them. Here's what happened. In general, those reports and what we hear at meetings and that sort of things is that in the patients for whom there's a decision made to use apixaban, rivaroxaban, or dabigatran, it's gone fine. They haven't had strokes and they haven't had too much in the way of bleeding, but there is some reports in the literature of bleeding, as one might expect. So it's still not really clear whether or not there's a subgroup of adult congenital heart disease patients that might benefit from these. There may be an increased risk of bleeding in patients who have significant valve disease and atrial fibrillation. And that actually comes from one of those trials I showed you earlier. They went and looked at those patients who were on the medications who had significant valve disease, but it wasn't significant enough to keep them out of the study, which is kind of a weird thing, but there you have it. And for whatever reason, there may have been an increased bleeding risk in those patients, and I'm not sure why that makes any sense, but that's just one study that's out there. So we kind of can't necessarily take that study and say, hey, based on this, if you happen to have, say, tetralogy of Fallot and your pulmonary valve has been replaced, then can I take these drugs or not? We can't use that study to kind of inform us so much. But so far, as reported in the literature, adult congenital heart disease patients seem to do fine. What is super important to know is that the initial trial of trying these in patients with mechanical valves, specifically mechanical aortic valves, had to be stopped early for an excess of clot risks. So for whatever reason, it was apixaban, I think, was used in patients with mechanical aortic valves and did not work. So it's a good cautionary thing that just because it works in one group of patients doesn't mean it's going to work across the board. Now, the one cautionary note I'll add to that cautionary note is that we said the same thing about Lovenox years ago. And at the time, they tried a trial of Lovenox. It was the drug company manufacturer doing it. And they had mechanical aortic valves and mechanical mitral valves, and they had an increased risk of clot formation, specifically with pregnancy. And so for a long time, there was what's called a black box warning. It was an absolute contraindication. You cannot use Lovenox or enoxaparin during pregnancy with mechanical valves. And if any of you have actually been treated with that, that is because as they actually studied it further, they realized that they were not dosing it appropriately. They were doing, instead of twice a day dosing, they were doing it once a day, and they weren't following levels and some other stuff that ended up being a big deal and that we do differently now. So I don't want to write off the idea that these drugs might not be effective for mechanical valves at some point, but so far they are absolutely not. though it may end up that there's either a better version of one of these drugs or a dose that works better or something that actually does end up being able to be an alternative to warfarin for people who have mechanical aortic valves, but if you have or mechanical valves in general. But if you have a mechanical valve, it is definitely not an option at this point in time to use any of these new oral anticoagulants. So what are the upsides and downsides, just as a rehash? The upside of these drugs is that rivaroxaban, at least, is a once daily drug. There's no lab draws. Thus far, they've been effective in studies of patients without congenital heart disease. And in the anecdotal experience we have, they seem to be effective, but it's anecdotal, so you got to take it with a big old lump of salt. Reversal agents are available, and there are very few drug interactions. The downsides are that 2 of the 3 are twice a day. And if you're not already taking twice a day drugs, that may not be something that somebody wants to sign up for. You can't assure that it's having its effect in terms of blood thinning. So you're making an assumption there. And that may be an okay assumption, but we just have to know that. It's not effective in mechanical valves. Assuredly, they're going to have ongoing efforts at trying to figure that out because there's too much of an opportunity there. But so far, it's not effective. The antidotes are available, but less available. So they're not as easy to reverse as Coumadin is. Renal function is an issue in terms of kidney function. If you have kidney function that goes up or down, that may not necessarily be the best drug for you. So in this particular topic, there really wasn't necessarily, I know these usually go upwards of an hour, but that was sort of my overview of the novel oral anticoagulants. And I think at this point, we can just tackle questions. I think the summary is they look like they're going to be really good drugs and that they'll be a good, viable alternative to Coumadin, that there's no real data that we can make decisions on for adult congenital heart disease patients. So you got to individualize your treatment options with your treating cardiologists and physicians. For people who've been taking Coumadin for a long time, their INRs are in range, they're used to it, there's probably not a whole lot of value to switching drugs. But for somebody whose INRs are all over the map, that can never get it regulated, and they need to be on some sort of blood thinner, it's felt that they're better off on it. That really may be a reasonable thing to talk about with your physicians. And for patients with things like Fontan procedures, it may turn out that those are good drugs for those patients. And hopefully, as time goes by, we're going to understand more as we get some of this registry data back and we have larger numbers of patients so we can really see how people are doing with these medications, make sure that there's not excess bleeding and that we are adequately preventing clot formation. So with that, I'll stop and see what questions folks have. I actually see one question typed up here. My daughter has a coronary artery fistula, which was closed. She later had a heart attack and is now on Pradaxa after not having success with Coumadin. Are there any studies that show that this is the best drug for her? In that specific setting, definitely not any specific studies that are going to compare Coumadin to Pradaxa for somebody who has a coronary artery fistula. I think that for coronary disease, there are patients who are on both of those, or there are some experience with coronary disease patients who've had heart attacks on Pradaxa or any of these other drugs, and some on Coumadin. I think that one, unfortunately, has to be really individualized. I will say that if she's didn't have success with Coumadin, being on Pradaxa instead makes perfect sense. Whether or not Pradaxa, which is the dabigatran, is better than, say, the rivaroxaban that's only once a day dosing, that you kind of have to sort out. If she struggles to take the drug twice a day, or if anybody does, if they forget one of the doses, then you really should be on one of the once a day drug. You should be on the rivaroxaban that's a once a day drug, because you're losing some of the effect there if you miss doses.
Great, thank you. I want to remind everybody, and first of all, let me thank Dr. Stout again for this really very informational and educational webinar. I know I say this all the time, but I really learned a lot from this particular webinar, as I do with most of them, but this one in particular, and I loved the comparison of the 3 different NOACs as well as Coumadin. So just want to remind everybody, if you would like to ask a question to Dr. Stout, please type it in the question and answer panel that's on your control panel. and we'll give you a few minutes. I know that I don't know if anybody's on any of these drugs that's had some experience they might want to share with us, because we do have some time before the end of the webinar to have a little discussion. So we will give you a few minutes to do that.
And Paula, I'll go ahead and while people are typing anything, and look back at one of the questions, which was a pulmonary valve surgery replaced with a Pig's valve, which is pretty common in our patient population,
Right.
on heparin during the hospital stay, which is typical, and then currently on warfarin. And right now, the standard, if you look at the valve disease guidelines, the standard is like for the first 3 to 6 months after a valve replacement to be on Coumadin. There isn't enough data out there yet on whether or not these medications are adequate for that situation. If somebody's INR is constantly below where it needs to be or is swinging wildly, it may be an alternative, but there's no data out there yet as to whether or not in that after surgery period, while we're trying to protect the valve from clot formation while it's healing in, whether or not these novel or the NOACs or DOACs are actually going to be effective in that setting. So I think if you can stay on warfarin and have good therapeutic INRs most of the time in that postoperative with a tissue valve, that postoperative period, that's probably fine. But if your INRs are all over the place, that'd be something that you could certainly talk to your regular doc about. But I'm not sure that it's at this stage that anybody would feel real comfortable saying it's as good as Coumadin in the postoperative valve protection phase.
Great. Thank you for answering that. So we do have a couple other questions coming in. I'll read them to you, and you can watch as I read them. We can all see them on our new software here. How difficult is it to transition between these medications? I think that's a great question.
It's actually pretty easy. So what they'll have you do is you stop your Coumadin until the INR is like it's 3 or 4 days. Drop the Coumadin entirely, and then after your INR is back down to basically normal, so it's usually 3 or 4 days out, then you start the new medication. One of the big advantages to these drugs, like rivaroxaban and apixaban both, is that they actually have an effect that comes on within a couple of hours. So one of the appeals of these things, if any of you have ever been what we like to call INR jail, if you've been stuck waiting for a therapeutic INR in a hospital, these drugs become therapeutic really quickly, and that's really appealing of them, or for them. So once you're off the Coumadin, thoroughly out of the system, then you just start these things up and off you go. So it's an easy transition. All right, I see another question here. At what point should a patient be switched from aspirin to warfarin or NOACs? My son has double outlet right ventricle with a Fontan repair and is a 20-year-old college student. His physician is now wanting to put him on an anticoagulant. So that's a really controversial thing right now. We don't really know what the right answer is for Fontan repairs. There's some studies out there that being on either aspirin or anticoagulant is a good thing, but then there's not any really good comparative data as to which one's better. So we try to use other additional markers of potential risk for clot formation. So whether it's arrhythmias, a prior history of stroke, what the actually echo looks like, and that sort of thing. There is starting to be a little bit of a leaning towards the idea that the anticoagulants, if we could do them, is not a bad idea, but that's a super individualized thing. I would say that I will switch my Fontan patients from aspirin to either a warfarin or NOAC, depending on what we're going to do. I usually start out with warfarin. If they have either a documented clot, if they have any arrhythmias, so any abnormal heart rhythms, particularly top part of the heart, which are pretty common in Fontan patients. If they've had a prior stroke, especially if it's unexplained, then I'll want them on an actual anticoagulant. And for pregnant women, I want them on something if they're pregnant. Although we don't, the warfarin, we can't use the novel oral anticoagulants in pregnancy yet. Warfarin has its own issues in pregnancies, but we'll want them on something in there. So that's a tough one, but it's a great question to sit down and have your son chat with his cardiologist about, to kind of see why on an anticoagulant now, what's different. But it's not an unreasonable consideration, or at least conversation to have. Let's see, we've got, do all hospitals have the reversal agents? I think they do at this time, but I don't want to swear to that. So I'm in Seattle, and it's we take care of a really huge area of the country, including patients from Alaska and Montana. And so some of those smaller care settings out there, like some of the acute care hospitals that are kind of treat and transfer, I don't know if they all do or not. I think they're getting much more broadly available, but I don't know the answer to that question, but I do think they are more broadly available. Somebody said, thank you, you're welcome. When I had my pulmonary valve replacement 20 years ago, I was put on aspirin 325 daily and remain on it. I've had AFib in the past, so if it ever returns, I'll be able to use the non-Coumadin drugs. Coumadin made me feel really sick to my stomach. It's interesting. That's not a widely reported side effect, but I've had a couple of folks have the same thing. So I do have some patients who had a pulmonary valve replacement, you know, many years ago, and now have atrial fibrillation, and similarly Coumadin doesn't seem to be a great drug for them. That is, I have a couple of patients who are on the novel oral anticoagulants. So right now, it depends a little on your insurance company. There's a lot of those that we can convince the insurance companies to pay for, because we say it isn't truly valvular atrial fibrillation. But some of them say, okay, fine, and others say no. So that is a circumstance where it's certainly worth a conversation. So if you have AFib in the past, again, and there's a desire to put you on an actual anticoagulant rather than just aspirin, then definitely it'd be worthy of having a conversation about those drugs. Because theoretically, you could have fit into that category of somebody who doesn't have valvular atrial fibrillation, and in theory could have been even in that study, or any of those studies, although they actually they excluded congenital heart disease. But in theory, you're as close as they come to somebody who could have fit in that. So yeah, totally reasonable to ask the question if it comes back, especially when you haven't done very well with Coumadin in the past.
Thank you. We just have a question that just came in.
Ah, brilliant. Ooh, better still. Cardiology clinical pharmacist. I love those, by the way. We love our cardiology pharmacists. Also work with our anticoagulation consult service. In your practice, do you find there are certain conditions or repairs you find physicians are more comfortable using DOACs with regards to adult congenital heart disease patients? Definitely. So I think that mechanical valves are totally out, and anything that's a surrogate for a mechanical valve, anybody who seems to have a really high risk of stroke is more likely to be on Coumadin. For Fontans, there's certainly been more of a leaning towards using DOACs when you're just doing sort of a preventative thing. When what you're most concerned about is venous thromboses, which is kind of where the Fontan thing comes from, then the DOACs have a bit more appeal. So kind of more right-sided conditions, venous conditions, I think DOACs are appealing in that setting. The other circumstance where I see it has less to do with certain conditions or repairs than it does age or job, where especially up here where we've got people who live so far away and maybe aren't near the anticoagulation consult services or clinics, it can be really hard to get them on, know that they're getting therapeutic Coumadin. And in that setting, if there's, like, let's say they have a history of an atrial arrhythmia and they had a stroke when they were young, and we have them on Coumadin because we're trying to prevent that, but their INRs are all over the place, and we still think that they need to be on an anticoagulant for some reason, then I will have a open conversation with them about the DOAC option, because I kind of figure that if we're never able to check your levels and we don't know that you're actually therapeutic, and when we do check it, you're often not, you got to be better off with the DOAC than with warfarin that's either too high or too low. So in that case, it tends to be less about the specific underlying condition than it is age and other social circumstances that maybe say the DOAC would be a better option, provided they aren't somebody who needs to have Coumadin otherwise. So like, again, mechanical valves, it's a no-go. But I would say use your pharmacist. I love having our cardiology pharmacists. They help us a ton with these things. All right, 39-year-old hypoplastic, yeah?
No, just say go ahead. We have one more question.
Yeah, 39-year-old with hypoplastic left heart syndrome, double outlet right ventricle Fontan in 1986, modified in 1997, stroke from AFib in 2001. Okay, recently asked why he wasn't on aspirin along with warfarin. He's been on warfarin since 10 days after his stroke. Has fairly stable INRs. Does weekly home testing to stay in a range of 2 to 2.5 via EP recommendation? Why would he also need to be on aspirin? I gotta tell you, that's a good question to have your son ask his treating docs. I'm not sure why. In general, one or the other. And in this case, definitely warfarin would be the go-to. If some people, if they've had a stroke on warfarin, then we'll add aspirin. And for many patients with mechanical valves, we will encourage them to be on both warfarin and a baby aspirin. And that's just for that, goes back to that whole clot formation of both cells and the proteins. We're not affecting the cells by being on Coumadin. And for some people, having that slippery platelets is also a good idea, but it makes them more prone to bleeding. So I don't actually know what would be added to why the aspirin as well. The one possibility is if anybody has any concerns that in addition to his congenital heart disease, he's developed coronary artery disease, aspirin is the standard prevention for that. And so there are a lot of older patients, not with congenital heart disease, but who have, say, atrial fibrillation where we want them on Coumadin or one of the novel oral anticoagulants. And they also have a history of coronary disease and they've had coronary stents and that sort of stuff, and they need to be on aspirin as well. So in those circumstances, each of those diseases is sort of being treated with 2 different blood thinners. So they're on the anticoagulation and they're on the antiplatelet agents because they need to be. But I don't, 39-year-old single ventricle physiology is not what I would typically think of as also requiring aspirin, especially with a Fontan that was modified presumably to a more modern version of the Fontan repair. I'm not sure why that would be. So that'd be a good thing for him to ask his cardiologist is what they're specifically concerned about and why the addition of aspirin.
Well, thank you. Thank you, everyone, for your amazing questions. And Dr. Stout, thank you so much for the time you took to give this webinar to us. Believe it or not, our hour is up and it's time for us to close. Reminding
Thanks,
everyone
everybody.
that we have, I'm sorry?
Oh, I just said thanks everybody for participating, and thanks Paula for organizing.
You're very welcome. We have recorded the webinar, everybody, and we will have it up on our website within 48 hours. So hopefully by the end of the day, Friday, if not before. I want to, we've thanked our sponsors, and just to thank them again, we could not do these webinars without their support. We also have a webinar fundraising campaign at ACHA, and the link to that will be in the follow-up letter you receive. And if you would like to make a donation to that, please feel free to, and I can assure you that any donation you make will go directly to webinars. You will receive also in your letter, your email after this webinar from me that just says thank you for coming and so forth. There'll be a link to complete the post-webinar evaluation. And I hope everybody will take 1 minute to fill that out because that's basically all it takes. It helps us in planning future webinars. I do share those with presenters and they are also very appreciative of the feedback. So please take a minute to do that and look for that to be coming in the next 24 hours. We do at ACHA endorse the ACC-AHA guidelines for the management of the adult congenital heart patient that state that all adults living with congenital heart disease be seen in an ACHD program at least once, and those living with complex CHD be followed by an adult congenital cardiologist. ACHA has a program directory of self-reported ACHD programs on our website, so if you need help finding that or want to talk to someone about it, just let me know. And if you want to talk to one of our wonderful heart-to-heart ambassadors, just contact me, and I can put you in touch with someone or tell you how we can get that connection going. Sometimes we found that it is very helpful if you're going through a situation to talk with somebody who's, if you will, been there and done that. So it's a very successful program. Lastly, our next webinar is in 2 weeks, Wednesday, August 28th. I hope you'll join us. It's going to be on psychosocial considerations in adult congenital cardiology, presented by Dr. Jamie Jackson, who is a clinical and research psychologist at Nationwide Children's Hospital and The Ohio State University. It should be a fabulous webinar as well. And the rest of the webinars for our 2017 series are available on our website. That's all I have for tonight. I want to again thank everybody for coming, thank Dr. Stout for her time, and hope everybody has a good rest of the week and next couple of weeks, and I'll see you on the 28th. Good night, everybody.